consultant psychiatrist Dr. Karthikeyan sir to deliver. So what are the psychological aspects that can occur in people with obesity? So he's a consultant psychiatrist currently working at Shanmuga Hospital. He has numerous publications to his credit. Sir, mic handed over to you.
In between, I would like to call upon the chairperson of the current session, Dr. Balaji sir, vascular surgeon from SKS Hospital, to accompany Dr. Sendil Raja sir.
Good morning to one and all. I thank you, Shanmuga Hospitals, for giving me this opportunity to speak about the psychological management of obesity. So what I'm going to talk about is how we are going, how to approach the psychiatric part, how we are going to manage the patients when they were coming for obesity. So as the speakers before me, speakers at Dr. Balamurugan sir, Dr. Satyaraghavan sir, has described how obesity is so prevalent that it becomes desensitized, that most of the people view obesity just as some sort of body profile. There has been lack of understanding about how obesity is a disease. So most of the people doesn't view obesity as a disease itself. They just view it as some part of body profile or for cosmetic reasons. For that, and the lack of understanding and the lack of risk associated with being obese is not educated to the people. So first is how people is viewing obesity. So what the basic understanding when people with obese, what they think about their body, how they look, how they view themselves. For some people, obesity is just like one of the body profile, like thin, athletic, fat. So just view it as one of the body profiles. For some, their looks has been affected. So because of that, they may develop secondary psychological symptoms associated with anxiety, depression, etc., etc. So other than that, there has been clear lack of understanding how to approach doctors to treat obesity, even if they are aware that the obesity is the reason for their poor quality of life, or obesity is the reason for their numerous psychological or physical health issues. Recently, just when I just crawled upon a Twitter profile, I just stumbled upon a video where a obese woman is giving interview how they have been oppressed, discriminated, bullied. So these people are subjected by other people because of their body image. So it takes a mental toll on them. So most of the obese people suffer from secondary psychiatric symptoms and even develop other mental illnesses. So even it's one part of how the people view. But in this new age, how some other part of people are viewing is that, for example, one obese lady has been suing the airline company about how her rights has been oppressed. So what's her theme is that she has booked, she couldn't accommodate in a single, you know about economic class flights. She couldn't accommodate in a single seat. So she had want to book 2 seats to accommodate her. But the airline, what they do, they just charged her for 2 seats. So what here is, so for that she has been fighting that obese people are being discriminated, oppressed, and they are not being viewed with other people as equal rights. They doesn't have equal rights. So what we can learn from this is there is a basic lack of awareness that people ask how obesity is not a disease. So first and foremost, we as a medical practitioner, when an individual approaches, we should view obesity, we should view and treat obesity as a disease rather than a risk factor for other physical or psychiatric diseases. So when you talk about treatment of obesity, it is not just about, not the sole purpose of treatment of obesity is not just about weight loss. It is more than that. It improves your health measures. It improves the quality of your life. That is the ultimate aim of the treatment of obesity. So your quality of life is improved and your health measures are improved, so you doesn't suffer or from lack of free life. So what in studies in US there is a study how the cost of health for an obese person is 43 times higher when compared to persons with normal weight. So just because with this information we know that how that obesity as a disease has major adverse factors and how it affects the health system and how it affects the society in general. So coming to the link between the bilateral relationship between, I will just talk about what the bilateral relationship between mental illness and obesity. So first of all, the psychological impact of obesity. Obesity, by being obese itself, people may experience many mental ill symptoms because of their body shaming, discrimination, bullying, and so much more. Because of that, they develop secondary depressive disorders and anxiety disorders. So these two are the most common because the people of being obese just because of how they view their body in a negative self state. Next is their biological factors. So it has been observed that obesity may change your brain structure and brain functionality. So this in turn causes other secondary psychiatric illnesses. This next is emotional eating. So most people who have been feeling stressed, who have been feeling anxious, so when they experience a period of episodic dysphoria, they tend to go into this maladaptive coping strategies. Coping strategies, what we say is, if we feel a negative aversive stimuli, our body wants to overcome this negative aversive stimuli so that we engage in activities to improve our mood. So in faulty mechanism, in people with this emotional disturbances, what they do is they indulge in overeating because of their emotional states. So what they say is these emotional states, they tend to overeat and to suppress the feeling of the aversive stimuli. So they tend to overeat and this in turn causes increased body weight of these people. Second is socioeconomic factors. So socioeconomic factors, the lack of safe food, safe access to fresh vegetables, fresh fruits. We have been using processed foods, ultra processed foods. So this can lead to obesity. And lifestyle factors is about sedentary habits. So most of us are working in IT profile and IT companies. So our regular day-to-day activities has been diminished. So this in turn causes both obesity and mental illness. So how it will affect, how mental illness can affect on the treatment of obesity, or how that obesity management of obesity can lead to secondary psychiatric symptoms. So mental health conditions like depression or anxiety sometimes hinder your treatment of obesity. For example, if a patient is anxious about cutting or changing their dietary habits, then they will not be motivated enough to undergo what we call as lifestyle changes in the treatment of obesity. If we want to enable the patient to make their choices, then we should first treat the associated mental illness. If they are associated with mental disorders like depression, anxiety, or some eating disorders are also associated with obesity. For example, binge eating and food addiction is also a common emerging topic which is associated with the development of obesity. So we need to treat these comorbid diseases so that the people will fully involved in the obesity treatment and they don't relapse. Because only if we treat the obesity and we doesn't concentrate on the mental illness, the mental psychological profile of the patients, then there is a tendency for relapse to prior behaviors which causes obesity in the first place. So for interventions, we need an integrated approach for treating both obesity and mental health. So some of the diseases which are were high risk for causing obesity, where first we will be talking about binge eating disorder. So it is a disorder in which there is a recurrent episodes of bouts of food intake occurs. So eating large amounts of food in a short space of time, and there will be no lack of control about the eating patterns. So the person continuously takes, there will be no control. Even after they feel full, after the satiety has been achieved, the patient continue to eat. So binge eating episodes are also any tree of eating more rapidly than usual, and then eating until uncomfortably full, and eating large amounts even when the patient is not hungry, and eating alone because of embarrassment. And because of this behavior, they tend to feel disgusted or guilty about their eating pattern. So to diagnose it, the binge eating should occur at least 2 days per week for at least a 6-month period of time, and it should not be associated with compensatory behaviors. Why they said about compensatory behaviors is the same diagnostic criteria is there for bulimia nervosa, where it is associated with a compensatory behavior. The compensatory behavior, in fact, in self-induced vomiting or using for Dulcolax tablets, soon after they eat, they use Dulcolax tablets or self-induced vomiting because of the guilt and the shameful behavior. They want to reduce weight. So they use this sort of maladaptive behaviors to decrease the weight. The concept that we can be addicted to food is gaining prominence nowadays. So it is a recently established disease where food addiction is the psychopathology, how food addiction acts is way more similar to the psychopathology of substance abuse, where the brain pathway, the reward circuit pathway is associated with development of food addiction. So most of the foods which we can be addicted to, the food should be highly palatable. Junk foods, which are high in salt, sweets, so extra calories, those foods are have a high potential for addiction. And ultra processed food also are responsible for food production. So this is a new disease which is coming into consideration. So diagnose food addiction for research purposes, they have been using Yale Food Addiction Scale. It is a 35-point self-questionnaire scale to diagnose about the severity of the food addiction.
Sir, since we are running out of time, sir, requesting you to complete in 2 minutes, sir.
So next we will be talking about the psychological therapy. So psychological therapy, how we are going to approach patients. So each patient should be individualized. It should not be given the same treatment modality shall not be applicable to all patients. So first will be motivational interview and behavioral therapy. So we are not talking about motivational therapy because it has been found to have no significant effect in the outcome of the treatment profile. So what we are doing is motivational interview. First we want to find out how motivated is the patient and what are the reasons for the patient to undergo, they want to come for obesity treatment. So we want to find out the motivation. So for that, we will be establishing about the client's behavior and desired goals. So what they want, and difference between resistance and lack of motivation. Lack of motivation is they understand that obesity is a disease and it causes other health issues, but they doesn't have the motivation to undergo treatment process. Whereas resistance, it's been like more like they don't understand that obesity is a problem and they are quite happy to live with as it is. So motivational scale. So with this we will confirm about the diagnosis, what the motivational stage of the patient is. So how important it is for you right now to change your behaviors and how confident are you that you could do it. So we are just asking these two questions to the patients who are come for obesity treatment. So to a scale of 0 to 10, we ask them, the patients, to report their score. Based on this scores, this is the theoretical stages of change. So in pre-contemplative and contemplation stage, we are not going to act or we are not going to give any therapy. Once after the preparation and action stage, the behavioral therapy and maintenance phase behavior therapy will be given. So what is the pre-contemplation phase is that we should just acknowledge the client's control of decision. So the patient is not yet ready for the change. So but we want to give them the benefit of doubt and we want to give you your opinion about the medical benefits associated with weight loss, and we want to also explore the concerns, whether you have secondary psychological concerns regarding their weight loss journey, and acknowledge possible feelings of being pressured to change. In the contemplation stage, so the pre-contemplation phase is when the patient scores 0 to 4, they are in the pre-contemplation phase. When the patient gives a score about 5 to 7, they are in contemplation phase. So validate the client's experiences. So these patients, more likely they have already tried some sort of weight reduction processes like diet or exercises, but they would have just given up because they doesn't attain significant weight loss. So restate the decision to change is still completely their own. So we want to re-emphasize that it's their own decision that they want weight loss, and clarify the pros and cons of changing behavior. What are the significant benefits associated with changing your behavior, and what are the difficulties? The difficulties most often involves the diet changes is that you cannot satisfy your palatable taste experiences and leave opportunity for continued movement toward the change. So behavior change is where we act. So you want to just price the individual's decision about for their motivation to begin their weight loss journey, and identify and assist their some problem solving regarding the obstacles, and we should go by step, encourage initial small steps, help identify social supports for these individuals, where group therapies, group social supports, where people like them, obese people, form a group and they will support each other, and provide further follow-up appointments to assist with adherence. So behavior therapy, what we will do is, we are going to change the dysfunctional beliefs and the perception of people about obesity, and we want to then modify the behaviors by changing the antecedents and the consequences of those behaviors. So in the behavioral therapy strategies, we just will be dividing into the 5 sessions about where we want to know about more about the patients, and the later 5 sessions will be more about helping and assisting the patients to continue their weight loss journey. So first session will be about psychoeducation and helping the patient in a goal setting, and the monitoring, self-monitoring of their activities and behaviors. Then session 2 involves knowing about their eating habits and how their family is very supportive and the family changes because of their diet changing habits. The session 3 will be assessing their daily activities and how they manage their time with their workload, and we help them assist in increasing their daily activity by managing their time. Then session 4 we will be talking about the food choices and how they should adhere to the strict diet plan, and they should go shopping and they should buy their own products and they should cook their own food to eat. And session 5 involves increasing exercise, and sometimes these people with diet plan, they suddenly because of the change in diet, they may experience lack of motivation or may stumble upon some obstacles. So we will help them in overcoming this problem, and we should adhere to the patients about why they started this journey and why sticking to this cause will enable and benefit them in the long term. So the behavioral therapy techniques we will be using is coping strategies and using helpful thoughts. And in session 7 we will be dealing about body image. So the benefit of body image the patient will experience, and we will be talking about it. And in the next session we will be talking about barriers and high risk situations. And then the 9th session will be about maintaining the change, and 10th is also maintenance and relapse prevention. So these are the behavioral therapy sessions we will be employed with the patients to continue their weight loss journey, and in the maintenance phase where self-monitoring will be given. The emphasis is stressed upon the patient himself, and then stress management, how to manage stress, the maladaptive stress pattern behavior, where if you experience stress, you don't involve in eating high food, and then better problem solving, and then cognitive restructuring. Cognitive restructuring is we want to act on the faulty belief, and we want to re-educate them, and we want to ask them to develop a new mode of skills so that they don't indulge in the faulty behavior. So we also provide psychological support throughout the bariatric surgery in pre-surgical psychological assessment, and continued need for surgery, continued need for support even after the surgery. We will be assisting the patients in maintaining their diet changing habits. So, thank you.
Thank you, sir, for the wonderful speech. Since we are running out of time, we can have a question answer session off stage or during the lunch session directly with the speakers. So I'm handing out the mic to the organizing team.
We thank the chairpersons and speakers for the wonderful session.